everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students. I've done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we'll be discussing in detail all about megaloblastic anemia. So two main anemias which come into megaloblastic anemia is the folic acid deficiency and the vitamin B12 deficiency. So we'll be discussing in detail uh, about these deficiencies in pediatric age. Okay. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily life classes. So there are various educators in this platform and they have regular classes happening in this platform. So you can attend your favorite educator's class, engage in discussions, ask your doubts, and all these doubts will be immediately answered in the live chat box. Okay, so also the structured course. So whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well. So by the time you give your exam, you would have to revise it really well, right? So that during the time of the exam, you remember all these topics well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and this is going to be a huge boost for your preparation. Next, coming to the live tests and quizzes. So whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what are your weak points and what are your strong points, right? So this is possible only if you attend regular quizzes and tests. So here in Unacademy, we have regular tests and quizzes happening, and this will help you to evaluate and analyze your performance. And as a result, you can concentrate on the topics which you are not good at. Okay. So also coming to the unlimited access. So once you subscribe to the subscription, you get access to all the classes which are exclusive to the subscription members. So even if you have missed a live class, you can go back and watch the recorded classes again and again. All this in the comfort of your home, in the comfort of your own device. So I highly recommend this platform. So first thing is the travel part is gone. So you save so much of time. Second is using this platform in the beginning part of your preparation will help you a long way. Okay. So next, so these are the top educators in the platform. They have regular classes happening and you can attend their classes as well. So the course is offered. So all the 19 subjects are required for your NEET PG preparation are taught in this platform. Okay, and these are the ongoing courses in our platform right now. Coming to the NEET PG subscription. So NEET PG subscription package. So as you can see, it varies from 1 month to 2 years. So I would suggest the 1 year or the 2-year subscription. So the 1-year subscription, okay, and also for the students who are in their NEET PG, who will be giving their NEET PG 2021, for them the 6-month subscription would suffice. So the 6-month subscription costs you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. Okay, and for the ones who are in their final year, in the 3rd year MBBS, or the ones who are in their internship, for them the 1 year or the 2-year subscription will be very helpful and reasonable also. Okay, so 1-year subscription is 25,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 22,500. And the 2-year subscription is 30,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 27,000. So this was about the NEET PG subscription package. So yeah, so if you are subscribing to this subscription, use my code Shilpa 10. Okay, so today's topic is megaloblastic anemia. So we'll be discussing about megaloblastic anemia. So firstly, the disorders which come under megaloblastic anemia are the ones who cause impaired DNA synthesis. Okay, so they cause impaired DNA synthesis. Okay, so RBCs are larger than the normal. RBCs are, so in every stage of development of the RBC, so RBCs are larger than normal. Okay, so now when you see the cell, there is a synchrony between the nucleus and the cytoplasm, okay, of the erythrocyte. So there is a huge asynchrony between the nucleus and the cytoplasm. Okay, so all these megaloblastic anemias will be associated with thrombocytopenia, Okay, leukopenia. Okay, and the peripheral blood smear, when you see, you can see large cells, large RBC. So when you do a peripheral smear, you can see a large RBC. And the neutrophils have hypersegmented nucleus. So this is a very important feature of megaloblastic anemia. They have hypersegmented nucleus. Fine. So that means what? They have more than 5 lobes. More than 5 lobes. Fine. So most of the cases of childhood megaloblastic anemia are because of the deficiency in folic acid and vitamin B12 and all the vitamins which are required for the DNA synthesis. The most common are the folic acid and the vitamin B12 deficiency. Fine. So next. So coming to the property. So now coming to folic acid deficiency. So coming to the properties of folic acid. Okay, the folic acid or pterygoglutamic acid. Okay, folic acid or pteroyl glutamic acid. So this, that is the folic acid, is the pteroic acid is conjugated with the glutamic acid, right? Is conjugated with the glutamic acid. Okay, now uh, these folates are to form the functional folic acids. These folates are reduced to tetrahydrofolate. Okay, tetrahydrofolates. Okay, this process is catalyzed by the enzyme dihydrofolate reductase. Okay, tetrahydrofolate. This is done by, okay, the enzyme dihydrofolate reductase. Okay, so these are the functional compounds. This is a functional compound, so we should know that. Next, so folic acids are available in most of the food items like the fresh vegetables, green leafy vegetables, fruits, and organ what is it, animal organs like the liver meat, the liver and the kidney. So there the folic acids are rich. Okay, so while in the vitamin B12, where only the animal products have which are rich in vitamin B12, but in folic acid even the plant sources are rich in folic acid. Okay, so this is what you need to know. And one thing is, if a child has been born with folic acid deficiency, the one thing is what, you know, the child will not present with folic acid deficiency, because the folic acid transfers through through the placenta, and that resource will be there for the child for at least 4 months. Okay, so if the child has um, certain deficiencies, maybe the mother's milk doesn't have enough folic acid, okay, that time the child might present between 4 to 6 months of age. This is even before the iron deficiency anemia. So in iron deficiency anemia, the child might present somewhere between 9 months of age. Okay. But in a child with folic acid deficiency, they present between 4 to 6 months of age. Okay. So now coming to the etiology. So the first etiology is if there is inadequate folate intake. So obviously, if you don't have enough folate intake, there will be deficiency of folic acid. Next is if there is any decreased folate absorption. So what does this mean? So there is some absorption abnormality. So it could be because of certain malabsorption syndromes, like for example, celiac disease. Next, there is congenital abnormalities in the folate transport and metabolism. So there are two conditions you need to remember here. One is the hereditary folate malabsorption, and the second one is functional methionine synthase deficiency. So I'll be talking about these conditions in detail. Okay, so now coming to the inadequate food intake. So inadequate food intake, so especially This happens when there is a high requirement of folic acid. So in conditions like pregnancy, okay, in adolescence where there is accelerated growth. So in here, if you do not take that extra folic acid in the food, it can lead to deficiency. So one thing is, it's very important during pregnancy. It's very important to supplement the pregnant woman antenatally with folic acid. So antenatal supplementation of folic acid is necessary, or else the children born to such mothers might end up having neural tube defects. Okay, so these children born to the mothers who are deficient of folic acid, they will not present with folic acid deficiency, because whatever folic acid, even if the mother is deficient, whatever folic acid the mother has, that will transfer in the placenta and the child will have the required folic acid required. But okay, but the extra which is needed is for the neural tube formation. Fine, that is one thing. Okay, next. Yeah, so children who are premature, who are very critically sick, children with other hemolytic disorders, these need extra dose of folic acid. So as you know, as I've told you already, the green leafy vegetables, fruits, and organ meats, these have high levels of folic acid. Okay, but oats milk, oats milk is deficient of folic acid, and as a result, children whose main diet is with goat's milk, they have to be supplemented with other sources of folic acid. Okay, so this is about inadequate food intake. So which conditions where there is higher demand for folic acid, where if it is not supplemented with enough folic acid, they can lead to deficiency of folic acid. Next, decreased folate absorption. So where do you see folate absorption being abnormal? So decreased folate absorption is seen in conditions where there is malabsorption. So where do you see malabsorption? So there is certain chronic diarrhea states. So chronic diarrhea or chronic enteritis, chronic infective enteritis, inflammatory bowel disease. So inflammation of the intestine, sorry, inflammation of the intestine. Okay, so here chronic diarrhea or the chronic infective enterocolitis. So one thing is giardiasis. Other thing for malabsorption is celiac disease. Okay, next, conditions where children would have gone through a surgery, bowel surgery, GI surgeries. Okay, okay, so there are certain drugs which causes malabsorption. What are the drugs which can cause malabsorption of folic acid? So drugs like phenytoin, rimidone, phenobarbital. So these are the conditions where the folate absorption is decreased. Next, coming to the congenital abnormalities in the folate transport and metabolism. So main thing you should know is the hereditary folate malabsorption. So hereditary folate, so these conditions are the inborn errors of metabolisms. Okay, so they come under inborn errors of metabolism. So next is the hereditary folate absorption. So hereditary folate absorption is a autosomal recessive disorder, right? So autosomal recessive disorder, over here the mutation is in the gene SLC4646A1. Okay, so this gene codes for a folate transporter. Okay, it decodes for a folate transporter. So and as a result, So now see there is a mutation in the folate transporter. That is why this leads to the malabsorption. Okay, over here what happens? So this is associated in there is folic acid or the tetrahydrofolic acid are not absorbed. Okay, and they become this symptoms become apparent by the age of 2 to 6 months of age. Okay, they'll have megaloblastic anemia, they'll have infections, they'll have diarrhea, they'll have neurological symptoms. What are the neurological symptoms these children can have? So these children can have seizures, right? They can have seizures, they can have developmental delay, they can have mental retardation. Okay, so this folate transport is not just impaired in the intestine, it is also impaired in the choroid plexus. Okay, so impaired the folate transporter, impaired transporter in the intestine as well as the choroid plexus. So you can see the choroid plexus are also affected, and as a result there is neurological symptoms in these children. Okay, so when you get a serum and a CSF analysis in these children, the folic acid is reduced in both. Okay, CSF and serum folic acid is decreased. So generally the CSF is to folic acid ratio is 3:1, and that is disturbed. Okay, fine. Yeah. Okay, so this is what in the management is you should give reduced folates, or the ones which can be absorbed directly where you don't need a transporter. Reduced folates are given as treatment. Okay, so next coming to the functional methionine synthase deficiency. So again, functional methionine synthase deficiency is a autosomal recessive disorder. Okay, so over here the mutation is in the gene which encodes for methionine synthase reductase. Methionine synthase reductase or methionine synthase, any one of this. So here these children will present with megaloblastic anemia, right? So again, one megaloblastic anemia they'll present. Along with that, there will be neurological symptoms. So they'll have cerebral atrophy. They'll have cerebral atrophy. These children will have nystagmus. They'll have blindness, and they have the muscle tone also will be abnormal. Muscle tone will be abnormal or altered. Okay, so now these children have the treatment in these children is hydroxycobalamin. Okay, so these children will respond to hydroxycobalamin. So remember, there is two things you need to remember. One is the hereditary folate malabsorption. Okay, so over here the folate transporter is defective, while the functional methionine synthase deficiency, which is required for the functional folic acid. So that the enzyme encoding for that is the methionine synthase reductase or the methionine synthase is mutated. Fine. So now the drugs causing a folate deficiency, not just the malabsorption, which cause a folate deficiency. So the first drug is the methotrexate. So methotrexate, what happens to methotrexate? So this methotrexate binds to dihydrofolate reductase. So I spoke about dihydrofolate reductase, right? So dihydrofolate reductase is required for the formation of tetrahydrofolate. So this methotrexate binds to dihydrofolate reductase, and this thus preventing the formation of tetrahydrofolate, which is the active form of folate. Next, other drugs like pyrimethamine. So pyrimethamine is used in the management of toxoplasmosis. So even this drug can cause folic acid deficiency. Okay, even trimethoprim. Okay, so these are the drugs can cause folate deficiency. Fine. So what are the clinical features? So you all know the clinical features include uh, what is it? They are listless. They are they have anemia. They are irritable. Okay, failure to thrive. Okay, these children can have hemorrhage because these are associated with thrombocytopenia. So thrombocytopenia with anemia, you should always think about megaloblastic anemia. So they can have hemorrhage. Okay, so these are the few neurological symptoms like seizures can be there. They can have tremors. So these are the condition clinical features you need to know. So when you do the laboratory finding, what do you see? The peripheral smear will show macrocytic anemia. The MCV will be increased. Okay, so that could be more than 100, more than 100. Also, when in the peripherals here you see multi-segmented neutrophils, the hypersegmented neutrophils, hypersegmented neutrophils. Okay, the retic count is low. So in a child who is on a treatment for megaloblastic anemia, in this phase of the treatment, when there is response to the treatment, that time the reticulocyte count can increase because there are a lot of immature RBCs which are produced. Okay, that's why a reticulocyte count be increased during the early phase of treatment of megaloblastic anemia. Okay, so the normal serum level of folic acid is 5 to 20 nanogram per ml. So deficiency is when the levels are less than 3 nanogram per ml. Okay, so this you should remember. But to tell this folic acid deficiency is chronic. So chronic. So to tell chronic for chronic folic acid deficiency, the best indicator is the RBC folate levels. RBC folate levels. Okay, to tell a folic acid deficiency is chronic, the best indicator is the RBC folate levels. Okay, so next, so the treatment includes either oral or parenteral folic acid, the dose being 0.5 to 1 milligram per day, and this therapy should be given up to 1 week. This dose 1 month, sorry, 1 month, that is 3 weeks, 3 to 4 weeks. Okay, so this dose should be continued for 4 weeks, followed by a dose of 0.2 milligram, 0.2 milligram maintenance should be given. So when there is deficiency, you give a oral or parenteral therapy of folic acid, that is 0.5 to 1 milligram per day. The child should be given for at least 1 month, followed by a maintenance folic acid therapy of 0.2 milligram should be given. And in children who have severe anemia, they might require blood transfusion. Okay, so blood transfusion in severe anemia. Okay. Next, so next coming to vitamin B12 deficiencies. This is another very important cause of megaloblastic anemia. So what are the properties? So methylcobalamin and adenosylcobalamin. So methylcobalamin and adenosylcobalamin. Cobalamin. These are the active, metabolically active derivatives of vitamin B12. Okay, the active forms. Now these forms are important for two things. So one is they are cofactors. They're important for as cofactors. Okay, in two essential reaction. One is in the methylation of homocysteine to methionine. Okay, methylation of homocysteine to methionine. So they are required as a cofactor there. Also, in another condition where they are important is for the conversion of methyl malonyl coenzyme A to succinyl CoA. So another important is one here. So methyl malonyl coenzyme A to succinyl CoA. Okay, the main dietary source is animal products. Okay, so animal products. Okay, so these are generally more common in older children. Okay, and if these are born to mothers who are very strict vegetarians or who are having deficiency of vitamin B12, they will present between 6 to 18 months of life. So they can present with severe tremor. Okay, there is another very important presentation in children, infants who have vitamin B12 deficiency is regression of milestones. Okay, this you should remember, this is regression of milestones. So these children, from the time of birth to the time of presentation, they would have attained normal milestones, but once the deficiency develops, the milestones will regress. So they would be able to stand before, but because of the deficiency they might not be able to even stand. That is very important in an infant who has vitamin B12 deficiency. They can develop present as tremors, only tremors, and also there might be history of regression of milestones. So this you need to remember. Okay, so now coming to the metabolism. So this is very interesting. So, and a lot of questions might come in the metabolism. Okay, so now we'll start from the beginning. So first, the you eat food. Okay, and the cobalamin is released from the food proteins. Cobalamin is released from the food that is in the stomach. So I'll put the organ here, stomach. So in the stomach, the cobalamin is released from the food. That is because of the peptic digestion. Next, this cobalamin, which is free now, which is released from the food, binds to haptocorrin. Binds to haptocorrin. So what is haptocorrin? Okay, it is it's a salivary glycoprotein. Basically it is produced by the salivary gland. So cobalamin binds to haptocorrin. Now this complex of cobalamin and haptocorrin, now that will go to the duodenum. Okay, so now what happens? Now in the duodenum there are these pancreatic proteases. This pancreatic proteases will degrade the haptocorrin. Okay, this pancreatic protease will degrade haptocorrin. So as a result, what will happen? The cobalamin will be released from the complex. Okay, so cobalamin will be released. So now what happens? Once the cobalamin is free, this cobalamin will bind to the intrinsic factor. So cobalamin, so I'll put cobalamin as CB, okay? This cobalamin will bind to the intrinsic factor. So in the intrinsic factor again is released from the gastric parietal cells, right? So cobalamin and the intrinsic factor will be there. So now this complex, okay, now they will enter the submucal cells of the distal ileum. Okay, now this is a receptor mediated endocytosis. So now if this is the cell, okay, there will be a receptor, that is the intrinsic factor receptor. So now this complex, this is the cobalamin and the intrinsic factor complex, will bind to this intrinsic factor receptor. Now this cobalamin, okay, now they'll, and as a result there will be, okay, they will endocytosis happens. So this cobalamin and the intrinsic factor enters the cell. Okay, so once they enter the cell, they will go to the lysosome. So over here in the lysosome, the intrinsic factor will be degraded. Okay, so cobalamin and intrinsic factor by endocytosis enter the submucosal cells of the distal ileum. Okay. Now here in the cell there will be lysosomal destruction or degradation of the intrinsic factor. So lysosomal, okay, degradation of intrinsic factor. So again the cobalamin will be free. So cobalamin will be in the cells. There are few cobalamin over here. They'll bind to the inside the cell. They'll bind to the transcobalamin. Okay, that is another transport protein. Okay, now in the cell they will bind to cobalamin plus transcobalamin. Now this cobalamin and transcobalamin, which is inside the cell, with the help of another protein, that is called the ABCC1 protein. Okay, with the help of ABCC1, it will move out of the cell and it will come to the blood. Okay, moves out of the cell, and will be in the blood. Okay, so always vitamin B12, the serum vitamin B12 is either bound to haptocorrin or it is bound to transcobalamin. Okay, now it is in the blood. So from the blood it can go to various other cells. So the various other cells, how can it enter? It can enter only if the cells have the transcobalamin receptor. So if they have the transcobalamin receptor, similarly like before, they will have, they'll undergo endocytosis, and this cobalamin and the transcobalamin complex will enter the cell, and like that, once it enters the cell, this transcobalamin will be degraded by the lysosomes. So as a result, the cobalamin will be in the cells. Okay, so did you all understand this? Should I repeat again? So in the blood, the cobalamin and the transcobalamin complex, with the cobalamin receptors, they enter various cells, and in the various cells there is transcobalamin degradation by lysosomes. Okay, and like that the cobalamin is free and it will be in the various cells. So this is how the vitamin B12 metabolism happens. Okay, so now coming to the etiology. So now the etiology, again it is similar to vitamin folic acid. So basically, firstly there is inadequate vitamin B12 intake. Okay, so if the intake of vitamin B12 is inadequate, obviously you will have vitamin B12 deficiency. Next, again, the impaired absorption. If the absorption is impaired, vitamin B12 deficiency can occur. Thirdly, the absence of vitamin B12 transport protein. So what was the transport protein I talked about? That was the transcobalamin. So if there is any absence of the vitamin B12 transport protein, again the absorption or the transport to the various cells will be hampered. Okay, so this is about the etiology. So now we'll talk about each etiology in detail. So coming to the inadequate vitamin B12 deficiency. So now this vitamin B12 deficiency, first, if the mother is deficient of vitamin B12, the mother is not able to transfer the vitamin B12 through the breast milk. So mother who is deficient of vitamin B12, and as a result the baby cannot have adequate amount of vitamin B12. Okay, so this and as a result these children can present with megaloblastic anemia by 1 year. So up to 1.5 year, up to by 1 year to 1.5 year of age, presentation will be at that time. So next, so in mothers, why do these deficiency occur? Okay, in mothers, why do these deficiency occur? This could be because of yeah, so infections like Helicobacter pylori. There could be celiac disease, inflammatory bowel disease like Crohn disease, pancreatic insufficiency. Okay, people who are strict vegetarians, okay, who don't even eat eggs or milk, so these patients also can have vitamin B12 deficiency. Okay, so as I've told you, like folic acid, even vitamin B12 transfers through the placenta to the fetus, and as a result these children will not present with vitamin B12 deficiency at birth. So there is a storage. So by the time of 1 year or 6 months to 1 year, they might present with vitamin B12 deficiency. Okay, so the daily requirement for vitamin B12 deficiency is, daily requirement for vitamin B12 is 0.4 to 2.4 microgram. Okay, so remember this. Next, so impaired absorption. So impaired absorption could be, one is if there is any gastric surgery, gastric surgery. Okay, or medications which can impair the gastric acid secretions, like proton pump inhibitors, this thing, the antihistamines, okay, like the ranitidine and all that. Okay, these medications which reduce the decrease the gastric acid secretion, so these can cause impaired absorption of vitamin B12 decrease. Okay, they can cause. Then so because these in case of intrinsic factor deficiency, so if there is intrinsic factor deficiency, then this cannot, again vitamin B12 is not absorbed. So I've told you in the previous metabolism slide, so how does intrinsic factor bind with cobalamin and gets enter the cells. Okay, so all this is very important. So next, coming to the hereditary intrinsic factor deficiency. So this is a part of the inadequate absorption. So hereditary intrinsic factor deficiency is a autosomal recessive disorder. Autosomal recessive disorder. So what happens here? So this is here what happens is these children will have early presentation between 6 to 24 months. Okay, and they'll have neurological symptoms along with anemia, neurological symptoms like ataxia. They can have paresthesias. Okay, they can be having hyporeflexia, but Babinski will be positive. Hyporeflexia, they'll have Babinski response. Okay, their tongue, they'll have the beefy red tongue. What is that tongue? It's smooth and red. Okay, smooth, red and painful. Okay, so in vitamin B12 deficiency, you should remember about the beefy red tongue. The tongue will be smooth, red, and it will be painful. Okay, so that you should remember. So a child who comes with this symptom, they might in children who have vitamin B12 deficiency, they will come with this symptom. Okay, it is very difficulty. Hermansky-Pudlak syndrome. So tell me about it. Hermansky-Pudlak syndrome. So I'm reading about it. No, not with vitamin B12. Okay, what are you talking about? Hermansky-Pudlak syndrome. Okay, so these children will have neurological manifestations. Okay, so this you should remember. And yeah, in these children you have to give oral reduced vitamin B12, which can be absorbed well. Okay, fine. Next is the Imerslin Grasbeck. It is Grasbeck. Okay, Imerslin Grasbeck syndrome. This is also an autosomal recessive syndrome. Okay, this occurs because there is a selective vitamin B12 malabsorption. Over here there is selective vitamin B12 uh, I don't know about that, Ganesh. So if I'll read about it and get back to you. So I've not heard about this, so I'll get back to you. I'm not sure about it. Hermansky-Pudlak syndrome. I've not come across that in my whatever I've read. I've not come across this. So I will get back to you into on Monday's class. Okay. So I don't know about this syndrome. I will let you know because I do not want to teach things which I am not sure of over here. So these okay. Fine. Fine. So vitamin B12 deficient, B12 in Imerslund-Grasbeck syndrome, these children will have selective vitamin B12 malabsorption. Fine. Selective vitamin B12 malabsorption. So over here, these children might will present within 6 years of age. Okay, the presentation is at 6 years of age. Okay, and these children, along with megaloblastic anemia, along with neurological defects, these children will have proteinuria as well. So proteinuria as well. So what are the neurological defects here? So these children will have hypotonia, developmental delay, they'll have brain atrophy similar to the previous one. Okay, so that is also there. So here, how do you diagnose? So this is diagnosed by one is low levels of vitamin B12, and again there is a genetic test which is needed to be done. The treatment over here is, what you should do is you have to give IM. You should give IM cobalamin, that is IM cyanocobalamin. Yes, so I'll get back to you because I'm not sure about this Hermansky-Pudlak syndrome. Okay, fine. IM cyanocobalamin. Fine. So next is the classic pernicious anemia. This classic pernicious anemia is more seen in adults. Okay, it is very rare in young children, but it could be present in adolescents. So that is called as the juvenile pernicious anemia when it is present in adolescents. So that is called as juvenile pernicious anemia. Over here, what happens? They have antibodies against intrinsic factor. Okay, against intrinsic factor. Okay, that is how juvenile pernicious anemia present. So these children have antibodies against intrinsic factor, and as a result the intrinsic factor is not able to bind to the cobalamin. Okay, so these children have immunological abnormalities. Okay, immunological abnormal, so it's an autoimmune disease, right? Immunological abnormalities. They'll have cutaneous candidiasis. Okay, they can have hypoparathyroidism. Okay, so over here, when you get a histology of the gastric mucosa, there will be atrophy of the gastric and achlorhydria. Okay, then the treatment over here will be parenteral vitamin B12. Well, and this is a lifelong treatment in these children. Next, coming to the vitamin B12 transport protein absence. So what is this? So over here there is the transcobalamin deficiency. Transcobalamin deficiency. Okay, so vitamin B12 transport protein, the transcobalamin deficiency is there. So I've told you in the metabolism, transcobalamin is very important in the transport of vitamin B12 into the various other cells. Okay, so that is also, if the transcobalamin is deficient, it can also lead to poor absorption of vitamin B12. So over here, this is an autosomal recessive disease. Okay, and because of the absence of the transport protein, the vitamin B12 is not absorbed. So here these children can present in the first few weeks of life, presents in the first few weeks of life. Okay, they'll have failure to thrive. Okay, they'll have diarrhea, vomiting. They can have glossitis, megaloblastic anemia, neurological symptoms. Okay, and how do you diagnose? So diagnosis becomes very difficult in these children because the transporter is abnormal. When you get a vitamin B12, it is normal. Vitamin B12 levels are normal, but the so the diagnosis becomes difficult. So in such cases, you have to do the levels of transcobalamin. So that is why the cobalamin levels of transcobalamin for diagnosis, because in these cases vitamin B12 will be normal. Okay, only the transporter is deficient, so the transporter is required to uh, transport into the cells and have the required vitamin B12 what's it effects. But since that is not there, that the vitamin B12 effects are not there in the body. But yeah, so to do a diagnosis of this, you have to get the levels of transcobalamin. Okay, so the management is either oral or parenteral parenteral cyanocobalamin. So this is the management. Okay, so next, yeah, clinical manifestation. So I've told you. So one is there is failure to thrive, there will be weakness, there will be lethargy, neurological manifestations. These children can have seizures, they can have developmental regression. So main very important thing in vitamin B12 deficiency in children is regression of milestone, regression of developmental milestone. So this you have to remember. Okay, so in vitamin B12 deficiency in infants, there is regression of developmental milestone. Rest everything is similar to other deficiencies. One thing is macrocytic anemia. They'll have lethargy, they'll have tiredness, fatigue, they'll have a neuroseizure, stroke. But regression of developmental milestones is a feature of vitamin B12 deficiency. In iron deficiency, what happens? There is impaired neurocognition. Okay, there is no regression of milestone, there is impaired neurocognition. Over here there is regression of milestone. Yes, yes, knuckle pigmentation is a knuckle pigmentation, yes, knuckle pigmentation. So knuckle pigmentation is another feature of vitamin B12 deficiency. I ITS, infantile tremor syndrome. That is why tremor, they're present with tremors with regression of milestones. Okay, is a feature of infantile tremor syndrome. Tremor syndrome. So children with tremors with regression of milestones are suspect with knuckle hyperpigmentation are suspected in children who have vitamin B12 deficiency, and these children are diagnosed as infantile tremors when they improve with vitamin B2. Okay, fine. Yes. So the lab findings. So we have to do the levels of vitamin B12. So there is nothing big about it. Vitamin B12 levels, the peripheral smear, the same as folic acid. And yeah, so this is it. I don't want to complicate this with anything else. Okay, so the treatment is with vitamin B12, either cyanocobalamin, cyanocobalamin, or hydroxycobalamin. That's it. Yeah, so this is over. So this is it about why megaloblastic anemia. So the main thing in this, I think, is the metabolism of vitamin B12. You should remember. So they might ask you questions on each step. Okay, so before entering the duodenum, which complex is there? Is it the cobalamin and the haptocorrin? So this metabolism of vitamin B12 is very important. So we will first see all the topics. What is important, we just discuss the important topics. Yeah, so to convert folate to tetrahydrofolate. So in folic acid deficiency, we talk a little bit about folic acid. So to convert folate to tetrahydrofolate, which is the active form of folic acid, you need dihydrofolate reductase. And if a child is born with a deficiency, if the mother has deficiency and the mother is not able to pass on folic acid to the baby through the breast milk, these children will present between 4 to 6 months of age. Okay, so inadequate folate intake, decreased folate absorption, congenital abnormalities in the folate transport and metabolism are the various etiologies. So in the congenital abnormalities in folate transport and abnormalities, you should remember the hereditary folate malabsorption and functional methionine synthase deficiency. Okay, so yeah, so inadequate food intake, you all should be knowing I won't discuss much. Decreased folate absorption, you should remember malabsorption. It's because of celiac disease and GI surgeries. Inflammation of the intestine, like inflammatory bowel disease, like Crohn's disease and Crohn's disease can cause malabsorption. And chronic diarrhea, like in giardiasis. So chronic infective giardiasis can cause folate malabsorption. Okay, and drugs like phenytoin, phenobarbital, primidone, you should know. Next, hereditary folate malabsorption. It is autosomal recessive disorder. The the mutation is in the folate transporter. So the folate transporter, the gene which codes for the folate transporter has the mutation. Okay. So these children present between 2 to 6 months of age, and they'll have a megaloblastic anemia along with neurological symptoms. So when you get the CSF and the serum folic acid levels, it is decreased. Functional methionine synthase deficiency over here, there is mutation in the gene which codes for methionine synthase reductase or the methionine synthase. Okay. Yeah, so drugs, this you should remember, drugs which cause folate deficiency. See, in the previously I said drugs which cause folate malabsorption, that is phenytoin, phenobarbital. But drugs which cause folate deficiency, it says like for example, methotrexate, it binds to dihydrofolate reductase. So dihydrofolate reductase in the properties, what did I say? From folate to tetrahydrofolate, if it has to be converted, the enzyme dihydrofolate reductase is needed. So while methotrexate binds to this dihydrofolate reductase, and as a result, folate is not converted to tetrahydrofolate. Okay, so pyrimethamine and trimethoprim are also drugs which cause folate deficiency. Okay, so yeah. So the normal folic acid level is 5 to 20 nanogram per ml. Anything below 3 nanogram per ml is deficiency. Okay, to check if this a child who presents to you with folic acid deficiency, to check if this child has been having chronic folic acid deficiency, then you have to get a RBC, the red blood cell folate level. Okay. So next, yeah, so coming to vitamin B12. So the active forms of vitamin B12 is methylcobalamin and adenosylcobalamin. So these two are very important in the formation of homocysteine to methionine, for methylation of homocysteine to methionine, and for to conversion of methylmalonyl coenzyme A to succinyl CoA. So these are very important cofactors. Dietary source is animal products, okay, like the organ meats, milk, curd. So these are all rich in vitamin B12. Children with vitamin B12 deficiency present somewhere between 6 to 18 months of life. They'll present with tremors, they'll present with regression of mitral. So as Ganesh said, that these children present with infantile tremor syndrome. They have knuckle pigmentation. Okay, so the next very important thing you should know is the metabolism of vitamin B12. So once the cobalamin is present in the body, how does it go through? Okay, how does it enter the various cells? So that is very important. So the cobalamin is released from the food, okay, uh, in the stomach via peptic digestion. So once the cobalamin is released, it binds to the haptocorin. So once haptocorin is a salivary glycopeptide. So once this haptocorin and cobalamin is bound, it enters the duodenum. In the duodenum, what happens? This haptocorin is degraded by the pancreatic protease. So now again the cobalamin is free. Now this cobalamin will bind to the intrinsic factor. So this cobalamin and the intrinsic factor complex will enter the submucosal cell of the distal ileum. So how does it enter? So these cells will have an intrinsic factor receptor. So this cobalamin intrinsic factor complex will bind to that receptor, and there will be endocytosis, and this complex will enter the cell. So inside the cell, there is lysosomal degradation of intrinsic factors. So that time again the cobalamin becomes free. So the cobalamin at this point binds to transcobalamin. Okay, so this transcobalamin with the help of a transporter ABCC1 will move out of the cell. Okay, so once it moves out of the cell, it enters the blood. So in the blood, always the cobalamin is either bound to haptocorin or the transcobalamin. So mostly the transcobalamin. Now this complex of cobalamin and the transcobalamin will enter various other cells. So these cells should have the transcobalamin receptor. So this complex binds to the transcobalamin receptor and enters the various cells. So once it enters the cells, there is the transcobalamin gets degraded by the lysosomal. So there is lysosomal degradation of transcobalamin, and then the cobalamin is free in these cells. So this is how there is metabolism of cobalamin happening in the body. So this you should know. Okay, so in anywhere when there is no intrinsic factor, what happens? When there is no haptocorrin, what happens? When there is no transcobalamin, what happens? So you should, okay, fine. So vitamin B12 deficiency can occur because, again, if there is low vitamin B12 intake, there is impaired absorption, there is vitamin B12 transport protein is absent. So what is the vitamin B12 transport protein? So over here I've said the most important is the transcobalamin. So if the transcobalamin is absent, again the vitamin will not be absorbed by the body. Okay, so that you should know. So yeah, inadequate vitamin B12 intake. So I've told you, if the mother is deficient of the vitamin B12, the mother cannot transfer the vitamin B12 to the baby through the breast milk, and these children will present to you by 1 to 1.5 years with anemia. Okay, yeah, and especially one very important history most of these children will come with is this generally the mother or the family is a strict vegetarian, so there is no other source of vitamin B12, dietary dietary what is it source of vitamin B12 in this. So that is why these children present with these deficiencies, and the daily requirement of vitamin B12 is zero point 0.4 to 2.4 microgram per day. Okay, so if there is any gastric surgery or if there is medications which reduce the gastric acid secretion, for example the proton pump inhibitor, so these conditions can impair the absorption of vitamin. Okay, so another very important thing, the so certain hereditary conditions which can impair the absorption of vitamin B12 is, one is the hereditary intrinsic factor deficiency. It is an autosomal recessive disorder. These children present between 6 to 24 months, they'll have neurological presentation, they'll have megaloblastic anemia, their tongue. So another very important thing is vitamin B12 deficiency, they have smooth red painful tongue. Okay, and another syndrome which has impaired absorption of vitamin B12 is Imerslund Grasbeck syndrome. Okay, these are autosomal recessive syndromes. There is selective vitamin B12 malabsorption. Okay, and these children will have megaloblastic anemia, they'll have having neurological symptoms. Along with that, they'll have proteinuria, and they might present between somewhere around 6 years of age. Okay, and the classic pernicious anemia is very rare in children. It is more of an adult thing, but in adolescence it can present. So these children, this condition when it presents in adolescence is the juvenile pernicious anemia. There will be antibodies against the intrinsic factor. Okay, and these children along with megaloblastic anemia, they'll have certain immunological antibodies abnormalities, they'll have cutaneous candidiasis, hypoparathyroidism, and these children require lifelong parenteral vitamin B12. Okay, yeah, so again I've told you about the absence of vitamin B12 transport protein, so the transcobalamin deficiency. Okay, so these children do not have transcobalamin, so they have so it is a hereditary condition, it is an autosomal recessive condition. Yes, correct, that is one more thing. Boiling reduces folic acid, heat sensitive, folic acid is heat sensitive, correct. Correct, Ganesh, that is another important point you should know. So that is why these fruits and vegetables, if you boil too much, it might lose the vitamin content in it, and that could be another reason to have a diet which is deficient of folic acid. So boiling too much of boiling of vegetables can lose the vitamin folic acid in it. Yeah, that is very right. It is heat sensitive, and folic acid is heat sensitive, and boiling reduces the folic acid. Very good. Okay, yeah. So in vitamin B12 transport protein, that is a transcobalamin deficiency, you have to check for the transcobalamin levels, because the vitamin B12 levels are normal and it might confuse you with the diagnosis. Okay, yeah. So this was about it. So today I was supposed to take atopic dermatitis. I have rescheduled the class to 9 a.m. on Monday. Okay, 9 a.m. on Monday. The a special class, Unacademy. Okay, that is the atopic dermatitis. Tomorrow at 10 a.m. 10 a.m. to 12 p.m. I'm having class on rheumatological disorders. Yeah, thank you, Ganesh. Yeah, rheumatological disorders. So I will try to cover as much as possible, but I have made it as part one for now. So let's see if there are some topics remaining. I'll come back in the some other class of special class. So this will be a 2 hour class on rheumatological disorders in childhood. Okay, so I have to see the previous questions. What are the most common topics which were discussed? So based on that, I will discuss these topics tomorrow. And on Monday in the YouTube class at 1 p.m. I'll be having hemolytic, teaching about hemolytic anemia. So in this hemolytic anemia, I'm not including thalassemia and all that. Okay, this with thalassemia sickle cell, this will be hereditary spherocytosis and all that. So other, not the main one. So other than thalassemia and sickle cell anemia, I'll be teaching that because thalassemia and sickle cell anemia, I'm having separate class. Okay, so other than that, so other hemolytic anemias, I'll be teaching on Monday at 1 p.m. So this is the time schedule for tomorrow and Monday. Okay, fine. So all the best, study well. So I always say discuss with your friends for half an hour to 1 hour. So that will also, de-stress. It will really give you some kind of relief from that entire studying entire day. It will make you feel good also. Okay, and be away from social media and study well. Stay safe. Be healthy. So good luck. Fine. Okay.